Welcome. In this video, we will work through a case of congestive heart failure as you would encounter it on the wards, following a single patient from their initial presentation to a management plan. We will cover the underlying physiology, diagnosis, and evidence-based therapies. Let's meet our patient, a 64-year-old man with a history of hypertension and a prior heart attack. He presents with 3 weeks of worsening dyspnea, leg swelling, orthopnea, and paroxysmal nocturnal dyspnea. Our learning objectives for this video include understanding the different classifications of heart failure, recognizing clinical presentations, interpreting the standard diagnostic workup, and applying guideline-directed medical therapy. The patient's story is clear. His dyspnea has progressed from exertion to rest. He now uses 3 pillows to sleep and has experienced episodes of waking up gasping for air. These are classic indicators of congestive heart failure. We must also consider his background. His history of poorly controlled hypertension and a prior myocardial infarction are major contributors to his condition. Furthermore, his type 2 diabetes and smoking history are important risk factors. Physical examination confirms his congestion. We observe elevated jugular venous pressure, bibasilar crackles, an S3 gallop, and pitting edema in his legs. These findings are all consistent with a volume overloaded state. Heart failure is a clinical syndrome, not a single disease. It occurs when the heart cannot meet the body's metabolic demands at normal filling pressures. It is the leading cause of hospitalization for older adults, with significant associated mortality. Clinicians classify heart failure in several useful ways: by output, side of the heart, timing of the failure, cardiac function, and, critically, by the ejection fraction, which helps guide our therapeutic approach. Pathophysiologically, heart failure involves 2 main issues: forward failure, which results in poor systemic perfusion, and backward failure, which leads to fluid congestion behind the heart chamber that is failing. Differentiating left-sided from right-sided failure is key. Left-sided failure causes pulmonary congestion, while right-sided failure manifests as systemic congestion. Importantly, left-sided heart failure is the most common cause of right-sided failure. When approaching left-sided heart failure, we assess ventricular size and function. We distinguish between systolic dysfunction due to reduced contractility, high output states, or excessive afterload, and diastolic dysfunction or pericardial disease. We categorize heart failure primarily by the ejection fraction. HFrEF, or heart failure with reduced ejection fraction, involves a dilated, weak ventricle. HFpEF, or heart failure with preserved ejection fraction, involves a stiff, non-relaxing ventricle. Treatment focuses on managing preload and afterload. Preload is the volume of blood stretching the ventricle, and afterload is the resistance the ventricle must overcome to eject blood. Therapies aim to optimize these parameters. The RAAS cascade is a compensatory mechanism that, in the context of heart failure, becomes detrimental by increasing preload and afterload. Modern medical therapies are designed to interrupt this cycle to improve outcomes. In summary, identifying the underlying etiology, whether it is coronary artery disease, hypertension, or other factors, is crucial. Understanding these mechanisms allows us to better manage our patients and improve their quality of life. We classify heart failure using 2 complementary systems. The New York Heart Association scale focuses on functional capacity and symptoms, while the ACC-AHA staging describes the structural disease and its progression. These tools help us track how a patient is doing and where they fall in their disease trajectory. Connecting symptoms to underlying physiology is essential. Left-sided failure causes pulmonary congestion, leading to dyspnea and orthopnea. Right-sided failure leads to systemic congestion, like JVD and edema. Forward, or low-output failure, presents with fatigue. Our patient unfortunately demonstrates signs of all 3 patterns. Using the Stevenson profiles, we can categorize patients at the bedside by asking 2 simple questions: is the patient congested or wet? And are they well perfused or warm? This leads to 4 profiles, such as warm and wet, which helps us immediately prioritize therapies like diuresis. Reading these profiles relies on specific bedside findings. Elevated jugular venous pressure is a key sign of congestion. In chronic heart failure, lung sounds like crackles may be absent due to lymphatic adaptation. For perfusion, we look for signs like narrow pulse pressure, which can indicate a low cardiac index. Our first-line diagnostic tests are the ECG and chest X-ray. An ECG can reveal previous infarctions or arrhythmias. A chest X-ray helps us spot cardiomegaly and congestion patterns like cephalization. Notably, lung ultrasound is increasingly used as it often outperforms the traditional chest film for detecting pulmonary congestion. To confirm and characterize heart failure, we use natriuretic peptides and echocardiography. BNP levels are excellent for ruling out heart failure. The echocardiogram is our most critical tool, providing essential data on chamber size, wall motion, valvular function, and ejection fraction to confirm a diagnosis of HFrEF. Beyond initial diagnosis, we must determine the cause and severity of the condition. Cardiac MRI helps distinguish between ischemic and non-ischemic causes, while angiography evaluates for coronary disease. Laboratory tests and, in severe cases, pulmonary artery catheterization help us assess end organ perfusion and tailor our management. Decompensation usually has a trigger. Common precipitants include dietary indiscretions, medication non-adherence, ischemia, and uncontrolled hypertension. We also screen for contributing factors like arrhythmias, infections, or acute valvular issues. Identifying and addressing these triggers is a fundamental part of restoring patient stability. For acute management, we use the LMNOP mnemonic, loop diuretics for congestion, nitrates for preload reduction, oxygen or ventilation, and proper positioning. Morphine is used sparingly. Treating the underlying precipitant alongside these measures is key to stabilizing the patient. Therapy must be guided by the patient's hemodynamic profile. Warm and dry patients need optimization of oral meds, while wet patients require diuresis. In cold or refractory cases, we may incorporate inotropes or vasodilators. It is important to carefully manage home medications during the stabilization phase. For chronic HFrEF, we use the 4 pillars of guideline-directed medical therapy: RAAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. Starting these early, at low doses, and titrating to target levels is the standard of care for significantly improving patient survival. Understanding how these drugs work is straightforward. Inotropes increase contractility, while beta blockers slow the heart, allowing better filling. Preload is managed by diuretics and nitrates, while afterload is reduced by ACE inhibitors and other vasodilators. Each drug class is specifically targeted to fix a piece of the heart failure puzzle. When implementing therapy, specific agents matter. We prefer ARNIS for RAAS blockade and evidence-based beta blockers like carvedilol. We monitor electrolytes while using MRAs. SGLT2 inhibitors benefit patients regardless of diabetes status. Additionally, devices like ICDs or CRT are utilized based on specific ejection fraction and electrical criteria. Our treatment strategy aligns with the ACC-AHA stages. Stage A focuses on risk factor modification. Stage B introduces preventative pharmacotherapy. Stage C requires comprehensive 4-pillar therapy and symptomatic management. And Stage D involves advanced care options like mechanical support or transplantation for refractory disease. Finally, we must recognize heart failure with preserved ejection fraction, or HFpEF, which accounts for about half of all cases. Diagnosis requires evidence of diastolic dysfunction. While treatment was historically limited, we now use diuretics for congestion and have confirmed the benefit of SGLT2 inhibitors for these patients as well. Before we wrap up, let's review some common pitfalls. Always remember that a normal ejection fraction does not rule out heart failure. You must also hunt for the precipitant for every decompensation, and don't abandon guideline-directed therapy for minor lab or blood pressure fluctuations. Start all 4 pillars and rely on bedside signs like the S3 gallop. Returning to our patient, he is a 64-year-old with HFrEF and an ejection fraction of 30%. He is currently warm and wet, requiring acute diuresis and blood pressure control. Our long-term plan centers on stabilizing his condition and initiating the 4 pillars of guideline-directed medical therapy. Let's summarize. Heart failure involves both forward and backward failure. The ejection fraction helps split our approach between reduced and preserved types. The RAAS system drives much of the congestion we treat. Diagnosis relies on exams and imaging, while treatment involves acute management and the long-term application of the 4 therapeutic pillars. This video was developed using current ACC, AHA, and HFSA guidelines, along with foundational clinical resources. All diagrams shown are original illustrations for educational purposes. Please consult with a subject matter expert to verify all clinical information before applying these concepts in your own practice. That completes our overview of congestive heart failure. An associated video that builds on these concepts is now available on your screen. Click the link to continue your learning or find it in the description below. Thank you for watching.